So for the next 20 minutes or so, I'm going to focus on spontaneous breathing in ARDS. And there's a little bit of overlap with what I'm going to talk about today with some of the stuff we talked about yesterday, and a little overlap with some of the stuff that I'll talk about tomorrow, but that's okay. Repetition is the key to learning. Nothing very relevant for this talk here. So if we're thinking about when to allow spontaneous breathing in ARDS, I think we really still have to focus on ventilator-induced lung injury, which is, and the prevention or minimization thereof. And we know a lot about, we know a lot about the mechanisms through which this happens, both at a physical level, at a biochemical level, overstretching of the alveoli, resulting in an inflammatory response within the lung that can spill over into the systemic circulation and cause damage to distal organs and drive multi-organ failure. And we showed this slide yesterday as the starting point for lung protective ventilation. We focus on limiting tidal volume, limiting plateau pressure, as done here in the ARDS network protocol. The whole protocol for this trial is still available online, and it's, say, long and complicated, but the way that they ventilated patients, this was very much as I said yesterday, a 20th century study where patients received volume cycled assist control ventilation for most of their episode of mechanical ventilation. There really wasn't very much spontaneous breathing allowed until the patients were almost better. In this trial, like this is the Love study, and you're not supposed to be able to read any of this. I just put this table up to highlight the footnote that in this trial and many other trials of lung protective ventilation, they do allow spontaneous breathing when patients are getting better. So for tidal volume, once patients reached an FiO2 of 40% and PEEP of 10 or less, they didn't care what the tidal volume was, which may be okay, but might be a challenge. Because the world is changing in terms of how we ventilate patients. In the top right up here, it's small because it's a clear message. These are the data from Andres Esteban's international surveys of mechanical ventilation. The first one up here was done in 1998, published in JAMA around 2000. And the pink bars indicate the number of patients still on the ventilator on any given day out to day 28. And the lines are the different modes of mechanical ventilation. So you can see in 1998, it didn't matter what day of the month it was. Everybody was on the same mode, and that mode was volume cycled assist control ventilation. But things have changed. We've gotten more comfortable having patients assist breathing and interact more with the ventilator. And these are the data from the 2010 version. And I dare to say when we repeat this again, we'll see even more of this. But you can see, fine, volume cycled assist control still most popular in the first couple of days, but a substantial portion of patients on pressure support ventilation, which is what this purple line represents. So that by the second week, then we have more people breathing spontaneously on the ventilator than we have in controlled mechanical ventilation modes. And that may be good. I showed these data yesterday, and here's a chance to look at them in a little bit more detail. That might be good. And we often think that, okay, having the patients breathe spontaneously, that must be good, right? We feel good because we're moving the patients towards a goal of liberation from ventilation. We may be able to use less sedation, and we feel like we're making progress. It may be good if we're able to maintain a relatively normal amount of effort in terms of their diaphragm function. Again, here are 107 patients followed with daily ultrasounds of the diaphragm, looking in the zone of apposition where we can see how thick the muscle is and how much it's contracting. Adjusting for these confounders, thickening fraction modifies the rate of change in thickness, i.e. how much the patient is breathing impacts what happens to the diaphragm over time. And if you don't use it, you lose it with a rapid decline in diaphragm thickness and atrophy. Whereas if you use it too much, injury might happen. Other things to consider when we're talking about spontaneous breathing and creating negative pressure within the chest, there may be an impact on the cardiovascular system. And we can generate large negative pressures into the interstitial fluid, into the interstitial space, which can potentially draw fluid out of the vascular component and contribute to the development of pulmonary edema. And finally, when we're thinking about spontaneous breathing, we have to consider the fact that the patient's own generated pressures may also injure the lung. We're very comfortable with the idea that positive pressure from the ventilator can be bad, but the idea that negative pressure from the patient can also be equally bad is a relatively new concept. And I showed this slide yesterday where patients can get into a vicious cycle of self-inflicted lung injury with high drive because of injured lungs. Is this a real thing, you might say? Well, I'll admit that there's still some debate. Notably, Martin Tobin is a skeptic about patient self-inflicted lung injury. But I think it's very clear that we can get ventilation-induced lung injury. This is an old experimental design where sheep were taken and they injected salicylate into the foramen magnum of some sheep, which makes them hyperventilate a lot. So you can see a significant increase in respiratory rate and tidal volume. But those animals with the added salicylate had severe ARDS on autopsy. No ventilators were included in this study, but they had autopsy findings indistinguishable from severe ventilator-induced lung injury. So really, we should be thinking about ventilation-induced lung injury that could be caused by the ventilator or by the patient. When patients are spontaneously breathing and they have significant lung disease, it can also, the air can go in and move around in different patterns. This phenomenon of Pendeluft, German literally for swinging air, is nicely demonstrated here using a electrical impedance tomography belt. And in patients where they have heterogeneous lung injury, like many of our patients, so they have some areas of consolidated lung and some areas of aerated lung, when large efforts are made, it turns out that all that tidal volume goes to one area of the lung first, and then it goes to another area of the lung second. So in effect, you took the individual alveoli, it's like they were exposed to a tidal volume that's twice as big as you thought they were, because it's not being shared equally. It's going all to one and all to the other afterwards. And again, I showed these slides yesterday where spontaneous breathing seems to have a differential effect depending on the underlying severity of lung injury. When the lung injury is mild, spontaneous breathing is helpful. When the lung injury is more severe, spontaneous breathing makes things much worse compared to no spontaneous breathing. And how we set PEEP on the ventilator may also impact how the patients interact with it. PEEP can have a strong effect actually on respiratory drive. If you have a lot of collapsed lung and you're able to open it, that can reduce respiratory drive a lot. And in this example here, in this animal pig model, we can see that between expiration to inspiration, when there's low PEEP and lots of collapse, you have lots of tidal opening and recruitment and de-recruitment every time. Things look much more stable with a higher PEEP, and the lung stays open and not so overstretched with each breath. It's a nice review article, a couple of years old now, that highlights a lot of these different and sometimes competing tendencies where we're trying to minimize lung injury, and at the same time paying some attention to diaphragm dysfunction. So far, I would say we have strong data to say that ventilator or ventilation-induced lung injury affects patients' outcomes in terms of mortality. Apologies. Whereas the diaphragm dysfunction, we have pretty strong data that this affects duration of ventilation, and recovery time, but probably not a direct effect on mortality. So I think our advice generally would be to focus on lung injury first, and then add focus on diaphragm dysfunction after you've taken care of preventing lung injury. So these are the questions that we're trying to ask: when to allow, how much to allow. And I'd say, like many things in medicine, it depends on what's happening with the patient. As I said, the benefits of allowing this is that, okay, we're letting the diaphragm work and preventing what we call over-assist myotrauma. You might have improved hemodynamics with less sedation and better venous return with some negative pressure in the chest. Less sedation required on all this associated effects, and maybe less delirium. And as I said earlier, you feel like your patient's making progress towards liberation from the ventilator. Obviously, if you're keeping somebody sedated and paralyzed on day 30, they still have a ways to go to get liberated. On the other hand, as I've tried to outline, there may be downsides, and you might have direct overdistension injury, pendulift, increased lung perfusion that we've had, dysynchrony, double triggering, and when you allow a lot of abdominal muscle activation, you can actually reduce end expiratory lung volume and worsen hypoxemia. And which of these things is more important probably is modified by the degree of severity of ARDS, how small the baby lung is, how high the patient's respiratory drive is, and what settings you have on the ventilator, whether how injurious they are. So we've been talking a lot about, okay, how to measure the patients might have a high drive and might be making very large efforts. Sometimes you might be able to qualitatively say from the end of the bed, yeah, the patient's working hard. They seem to be making large efforts. But it's actually very useful and easier than you think to quantitatively assess how much effort the patient is making and how much they're contributing to the overall distending pressure of the lung. And there's at least 6 ways that you can do that listed here, and I'll go through each of these in a little bit of detail. So probably the gold standard for this would be the use of esophageal manometry as a surrogate for measuring pleural pressures. This is a nice review article in intensive care medicine that walks you through a lot about the underlying principles of and how to use an esophageal balloon. If we look at a graph here with airway pressure, flow, esophageal pressure, and transpulmonary pressure here, we use esophageal balloons. Increasingly, more and more ventilators have a port where you can plug the esophageal balloon directly into the ventilator, and the ventilator will then display the esophageal pressure and the transpulmonary pressure in centimeters of mercury. I find that much easier than when you try to connect the esophageal balloon to a typical pressure monitor that we might use for CVP or for blood pressure. A, that puts it up on the monitor over here and not on the ventilator. And B, it displays it in millimeters of mercury instead of centimeters of water, and it becomes difficult. So practically speaking, it's much easier if you can find a vent with an auxiliary port and plug it directly into. And then this is an example of a so-called Bader maneuver. You want to check that it's in the right place. You put a small amount of air in the balloon, and with an expiratory hold, so there's no flow, you push on the patient's chest, and you should see an equal or within plus or minus 20% rise in airway pressure and esophageal pressure that tells you, okay, the balloon is in the right place. And then you can go ahead and look at efforts that the patient is making with each breath. Here, not very much. And you can calculate transpulmonary pressures and the like. Another way to measure effort is, and this is, I would say, available on some, but not all ventilators. Some ventilators don't allow you to do this, is to do a plateau pressure maneuver in a spontaneously breathing patient. And sometimes you get a result that looks like this. It's like, oh, that's weird. I thought the plateau pressure was supposed to go down. And the peak pressure, by its name, was supposed to be the peak. But in fact, that's not the case. In a spontaneously breathing patient, and somebody's done pressure, for example, pressure support of 5, low levels of pressure support, and they might be making relatively large efforts. So they make a -20 effort when they take a breath in, when they lower their diaphragm. The ventilator pushes more flow in to overcome that, and the ventilator's mission is still to raise the overall pressure by 5 centimeters of water. And what you do when you put an inspiratory hold at the end of the breath, the patient stops their breath and their diaphragm comes back up, and the pressure in the circuit rises to the same extent as the patients had created a negative effort when they were taking a breath in. So that this inspiratory spontaneous plateau pressure above the peak pressure may be useful and available to measure in some ventilators. You do need to, obviously in this example, you need to be careful that the patient's not fighting it and coughing and taking another breath in. But when you get a nice flat line like this for a few seconds and there's no major derivations there, you can be confident that that probably is the true plateau pressure in a spontaneously breathing patient. Another marker that's a measurement that's useful at measuring drive and hinting at effort is this measurement of P.1. This is a measure that's literally, it's the pressure drop in the first 100 milliseconds or 0.1 seconds that's generated by the patient when they make an effort, when they take a breath in. Apologies for my slides here. And this is not a new measurement. I think it was first described in 1953. It's been on ventilators for a long time, but we haven't really paid much attention to it until recently. This is a marker that's really indicates the patient's drive. It's relatively independent of volitional effort. And it turns out, Irene Tellius has done some of this nice bench work that almost all ventilators have a display of P.1 on them, either sometimes automatically, sometimes you have to do a little bit of a maneuver to generate it. And it turns out in most of them, the value displayed on the ventilator is quite accurate compared to a gold standard bench measurement using a pneumotac and a proper manometer. So you can use that value that's displayed on the ventilator. One caveat being the Siemens servo ventilators, which don't actually do an occlusion maneuver and sort of estimate the P.1. They might not be as accurate. But using thresholds here, you can see the ROC curves for using a value of less than 1.5. If the P.1 is less than 1.5, you can be very sure that the patient is making very small efforts. And if it's greater than 4.5, you can be quite relatively sure that the patient's making relatively large efforts. Now I want to walk you through something I talked a little bit about yesterday. This is the expiratory occlusion maneuver, or the POC. I think this is more readily available on almost every mechanical ventilator now, and it helps us measure the iceberg of what's going on underneath. So if you look at peak pressures, you would say, oh, patients on controlled ventilation have higher pressures than patients on assisted ventilation, i.e., we often set higher levels of pressure control than we set of pressure support. And if you were measuring the driving pressure just in the ventilator, you would say, yeah, that's higher on pressure control levels or volume cycle assist control than it is on pressure support. But if you actually measure the transpulmonary driving pressure using an esophageal balloon to know what's really going on, there's no difference between these modes of ventilation. And you don't know that unless you make some measurements and measure efforts. So this is as we go down here, flow, airway pressure, esophageal pressure, transpulmonary pressure of the lung, of the chest wall, muscular pressure, and electrical activity of the diaphragm down here. So we come in and we do an unannounced stealth expiratory occlusion. The patient doesn't know it's coming, and so they make an effort. That the key down here is look at the EDI. The electrical activity of the diaphragm is the same on every breath. So it's not an exaggerated breath that they make against the closed airway. And the occlusion pressure is generated. The esophageal pressure, you'll note, is more negative than the other ones. Again, that's an exaggeration because there's a closed airway against which the muscle is working. So it's just a correction factor that's needed here. And that's where we can estimate the PMUS as 3/4 of the occlusion pressure, and we can estimate the total transpulmonary distending pressure as the positive airway pressure that's being delivered, peak airway pressure minus PEEP, and then we add the contribution of the patient by adding 2/3 of the POC. So that's a very simple way that you can measure your patient's efforts. And I got to say, when I'm doing rounds in the unit, for every patient who's breathing spontaneously, I want to know the P.1 and I want to know the POC, because knowing the patient's on pressure support of 5, I don't know does that mean that the lung is getting a very gentle 5 centimeters of water distension pressure, or is the patient generating 35 centimeters of water on top of that? That's a totally different clinical situation and a totally different risk scenario for the lung. Anybody like to use proportional assist ventilation in the room? It's available on some Mackay ventilators. It's a very nice, it's like power steering for your lungs, a Canadian invention by Magda Eunice. We like it in Canada. But the way that PAV works basically is it measures work of breathing using the equation of motion every 5 milliseconds and provides extra flow in the next 5 milliseconds to account for X% of that work of breathing that you've just measured. So knowing that, you can use this mode to also measure patient effort. Because you look on the ventilator and say, okay, if I have somebody on 50% support on PAV, and that is generating a delta pressure of 10 on the ventilator, peak minus PEEP, then I also know that the patient's making an effort of 10 because the ventilator is doing half. So if 50% equals 10, the other 50% equals also 10. And if they're not actually on 50%, you can do some grade 6 math to figure out if 35% equals 10, what does 65% equal? So I tried to outline several ways that you can quite easily quantify patients' efforts at the bedside. And then the question is, okay, efforts are high. How do I get them down? If we want to decrease spontaneous efforts, obviously the first thing to do is, if you have some control, decrease the amount of positive pressure that you're delivering, and that may lower tidal volume. But increasing the inspiratory assist here, if the patient's making very big efforts, sometimes will allow the patient to relax a little bit, and your overall distension might go down a little bit. But you do have to pay attention to tidal volume and your overall distending pressure. As I hinted at earlier, increasing PEEP, if you were able to generate some lung recruitment and get the patient at a better end expiratory lung volume, that will sometimes decrease drive and allow the patient to be breathing safely, spontaneously. Obviously, one way to perfectly control patient effort is to paralyze the patient. Then you've just traded one problem for another problem. Another two intriguing ideas that I'll get into in a second are using partial neuromuscular blockade and using extracorporeal life support to help diminish drive. This is a sort of feasibility study from Leo Hunk's group showing that you can, in fact, with careful titration of neuromuscular blockers, just not paralyze the patient, but weaken the diaphragm a little bit so that high pressures are not being generated. And they were able to, over the course of a few minutes, get patients' tidal volumes down and keep them there for an hour with intermittent or small doses of rocuronium or cisatracurium here. So whether this is feasible, how feasible this is in the longer term, we do this occasionally, and patients, obviously they need some sedation while you're doing this, but you can still maintain their diaphragm working a little bit while still not generating too much of a high tidal volume and high pressure. And the last couple minutes, just to talk about using extracorporeal life support to adjust drive. These are old data from Ted Cobolo and Luciano Gattinoni from the NIH in the 1970s, but essentially showing that you can in a healthy subject, by removing CO2, you can completely control their drive to breathe. And the whole concept of using extracorporeal CO2 removal with low frequency, low positive pressure ventilation is not a new one here. This is JAMA 1986 proposal for this. The key is you have to be able to remove a lot of CO2. And as we talked about yesterday, some of our current sort of dedicated ECOR devices don't really remove very much CO2. So we may be using full flow ECMO, but it probably is better termed extracorporeal membrane oxygenation and CO2 removal, or maybe just extracorporeal life support for short. This definitely is feasible to do in real patients. Data from Christian Karagianakis here showing that at least in the recovery phase of ARDS patients on ECMO, you can make the EDI, the electrical activity of the diaphragm, go up and back down again, simply just by adjusting the sweep on the CO2 on the ECMO circuit. And similarly, you can make the tidal volume go up and go down by coming up and down on sweep. The key is you have to be able to remove a significant amount of CO2 to do this. So this won't work if you're just doing low flow, low efficiency CO2 removal. So at the end of the day, what do we do here? In my opinion-based medicine, when the X-ray looks like this and the lung injury is severe, we're probably focusing on lung protection and not so much spontaneous breathing. As we're getting over here, thinking about more spontaneous breathing while still keeping the lung safe, you probably have more room to maneuver with driving pressure when the patient's X-ray is looking like this. So I've tried to tell you that the impact of spontaneous breathing during ARDS depends both on the timing and the severity of the underlying disease. I've tried to make the point that measuring patient efforts while spontaneously breathing is important and actually pretty easy to do. And when you're allowing spontaneous breathing, consider normalizing efforts to protect both the lung and the diaphragm, especially early on. And with that, I'll stop and be happy to participate in the question period at the end. Thank you very much.